The most frequently asked questions in interceptive preventative orthodontics that I'm going to answer for you now. So this question you have, which many times never found an answer in that video, because we are going to answer it now. My dear friends, welcome to this video. I'm recording this video on my cell phone because I recently opened a question box and selected some of the questions to answer for you. They are super good and frequently asked questions about preventative and interceptive orthodontics. If you would like to ask your question, please send it and we can make it a future video on the channel. Take advantage and go to Instagram, Rayane Pinto, which is my Instagram. Every week, I post a question mark emoji, and I'd be happy to answer your question too, which could lead to a video for this channel. Today, we have questions about all these devices. We have questions about expanders, about pseudo class 3. So please take advantage and leave a like on this video so the YouTuber really knows about the work we do to support the channel, and also remember to subscribe. Subscribe to the channel to receive all video notifications. There are always new videos here on the channel every week. Regarding the sequence of arcs in 4x2, is it handled normally? So it's a question, it's a question from ivodental.coe. I don't know what would be normal for you, but maybe he's talking about the conventional sequence. From 0.12, 0.14, 0.116, nicotine, 0.18, 0.20, there goes for the steel arches, then the rectangular nicotine ones, then the rectangular steel ones. And just to clarify, no, for the 4x2 treatment with children, we only use round arches and not any other type of arch at all. So our sequence of arcs is divided into 6 arcs, a maximum of 6 arcs, sometimes even less. So the patient has a rotation, a very large crowding. We start with 0.12 nickel titanium, then we go to a 14, a 16, and 18 nickel titanium. And then we go for 18 steel and finish, if necessary, with 0.20 steel. Notice that there are only round arches in this sequence because this patient still has open apices. We don't need toric reading at this time, and this is the reason. This sequence of arches and a very short treatment of 6 months are proposed for interceptive orthodontics cases. Okay, answered? Yeah? Next question, Romy's question, who asks, why should a Hyrax be used for 6 months? And what if I still don't have the space I need? Well, so first of all, we should use the Hyrax for 6 months, and this is valid for both Hyrax and Haas if you're doing a rapid maxillary expansion, okay? And that's primarily because after we perform the rapid maxillary expansion procedure, there is a complete and total separation between the maxillary base and the circummaxillary sutures, and it actually needs a certain period of time for new bone neoformation to gradually occur in that area. This is the period that has been clearly proven by the scientific literature, especially in the work from Dr. Omar de la Silva Filo, which shows that it takes a period of approximately 4 to 6 months for complete new bone formation to occur. And due to variability, it's better to wait the 6 months. And if you still don't have the expansion you need, here's a helpful tip for you. Number 1, don't use a rigid expansion protocol where you only activate for 10 days or only for 14 days. No, expand as much as you need. So until you achieve complete overcorrection. If it takes 16 days or 18 days, do it, okay? So you don't run into the problem of feeling like you should have opened the screw more, but you didn't manage to. And in those cases where you're gonna use a new expander, after waiting 4 or 5 months, you can then start a new maxillary expansion, okay? But it's actually a mistake. It qualifies as a mistake if this problem happened because you didn't activate it enough. Next question. In the case of a pseudo class 3, what appliance options do we have? Number 1, what is a pseudo class 3? So we have skeletal class 3, dental class 3, and pseudo class 3. So skeletal class 3 is a class 3 that presents with a dental class 3, but is also accompanied by a skeletal problem, meaning either maxillary retrusion or mandibular prognathism. Dental class 3 is due to a retroclination of the upper incisors or a protrusion of the lower incisors, and that's why it's in a crossbite and in a class 3 position. Knowing that a pseudo class 3, or what is also referred to as a dental class 3, is a type of treatment that typically doesn't require any skeletal management, one of my main appliances that I frequently use for this particular situation would be the Progeny appliance. So the Progeny appliance, which is the specific orthodontic appliance that we use, is designed to treat what is known as pseudo class 3 malocclusion, primarily because it features this distinctive Eschler arch. And this Eschler arch, which is a unique structural component, causes the upper incisors to protrude forward and the lower incisors to retrocline, or tilt backward, which in turn helps facilitate the correction of this particular type of pseudo class 3 malocclusion in patients. So it works really well, and you can even add these resin bite ramps if there's an associated inverted deep bite. All right, another question. A patient in treatment with a clamped didn't use it and came back after 3 months with a posterior open bite. What should I do? So Dr. Aluna Resin. Dr. Aluna Resin, first, if this patient didn't use it, of course, I don't have photos of what this posterior open bite looks like. But if the patient didn't use it, you should abandon any expectation that this patient will be cooperative with any type of removable appliance. And if they have a posterior open bite, I'm just guessing here, but it could be that this patient is in the second transitional period of mixed dentition, where the premolars are being exchanged, the deciduous molars for premolars, and maybe there was a period where they were placing their tongue laterally. Observe this patient's transverse dimension carefully to see if the palate is truly the right size for the tongue's ideal positioning. And also, observe the patient's functional issue in detail. Why are they lateralizing their tongue, Take note of any patterns or reasons that might explain this behavior. So there are two options. Either adjust the transverse space of the maxilla with an expander, or send this patient for tongue therapy. I don't know why you use the clamped, but those are two options that can be done. Okay? Another question, and for this one, I'm even going to grab an appliance that wasn't here. An appliance that I love it. My favorite. Here it is. What do you do during a checkup for an Andresen activator? I don't know if you know this wonderful appliance, which is the Andresen activator. This is an activator. It's a mandibular propulsion appliance, the Andresen activator type. The Andresen activator is made of a single structure, where I have a vestibular arch, an Adams clasp for retention, and I generally like to also place a little retention hook here. I have this anterior part, which is the anterior shield where the lower incisors fit, and something very good, which is the expansion screw, which can also perform a dental expansion of this upper arch. This upper arch, which in a class 2 pattern patient is generally atresia. So I position the patient's tongue very well, and I also perform expansion and advance the mandible, having enough posterior acrylic to be able to grind it down and also correct the deep bite. So what do I do during a checkup for an Andresen activator? I activate the clasps, number 1. So I take my bird beak pliers. I can close the activation omega of the vestibular arch. I can close the little hooks of the Adams clasp. So I activate the clasps. Number 2, I activate the expansion screw to expand. Number 3, I carefully grind the acrylic material in order to solve the issue of the deep bite. So these are the 3 important activations, the 3 essential guidelines for you to follow and keep in mind during a checkup appointment with the Andresen activator appliance. Greetings, dear doctor. What glass ionomer do you recommend for cementing bands? Look, we're already off to a good start with glass ionomer. We really should not use resin cements on children because honestly, it's just a waste. you end up wasting the valuable opportunity to have an excellent, truly wonderful dental material that can actually release fluoride into the patient's mouth and help to prevent the development of cavities. So preferably, actually mandatorily for any fixed appliance like a quad helix, for example, a Hyrax, or any other fixed appliance, you must use glass ionomer cement. I recommend a glass ionomer cement that is specifically for cementation. Some are for restorations, but the one for cementation is the right one. There are many good brands like Maron, which is excellent. There's a Brazilian brand, which is Vidrion C for cementation. They are all excellent, all right? You don't need an incredible, super expensive glass ionomer, no, because the secret to the appliance's retention is the adaptation of the bands. The cement is just there to be an interface, a contact between the band, which has good retention, and the patient's tooth. And the last question, in interceptive orthodontics, do you treat the patient's midlines? And this is a good question because, of course, we do. We are concerned with treating the patient's midline, and we have a few ways to treat the patient's midline in interceptive orthodontics. One way would be with the maxillary expander itself. So by controlling the space closure of this expansion of the interincisal diastema using an anchorage with a button and a metal ligature. The second way to center the midlines would be with serial extraction. So with serial extraction, when a patient loses a deciduous canine, for example, I'm obligated to extract the other deciduous canine to center the patient's midline. And the third very common way we have to solve the patient's midline problem is with the 4x2 appliance. Specifically, this is where I can activate open springs, the so-called open coil, more on one side than the other as needed in order to regain space and center the patient's midline. I hope you all enjoyed these frequently asked questions in preventative and interceptive orthodontics. We really enjoyed it, didn't we, Edgar? I liked it. How can I put it? A lot? A lot. You loved it. I loved it. Very good, very good. So if Edgar liked it, that's great. My dear doctors, if you want to ask a question, then go over to my Instagram, where I put up a question box every week, or leave your question here in the comments of this YouTube video, and I will be very happy to answer them. And there's a question that's being asked quite frequently, which is, Doctor, when are you opening spots for the next Intercept course group? And that's an answer that I'm only going to give to the doctors who are on the waiting list for the course, because the doctors who are on the waiting list receive the important information in advance before anyone else. So if you want to treat 100% of your interceptive orthodontics patients, get even better results, successfully treat these patients, modify and guide their growth, and also benefit your clinic by increasing your profits through these incredible and transformative treatments, which for me is also my purpose in this field, then the Intercept course might be the place for you. Just leave your name and your best email, and when we have openings, we'll get in touch with you. All right? My dears, a big kiss to you all, and see you in the next video. Kisses. Bye.